Hi, welcome back to part 2 of 8 of my abnormal psychology revision, in which 7 videos and 1 podcast episode, because the podcast episode is me going through past papers I have found, and I do not have the capacity to sit down and start recording everything from the past papers. Another thing is, in all these videos, there are particular parts where I have comparative tables. I have tables, and so I've made templates on Canva, and they are free to view, free to download. They could help you in your revision or something. And for me, they are helping me in my revision because I read my notes. I come and film a video. I explain a bit when filming the video and reading my notes, and then I go on Canva, and then I make the comparative tables and everything to help me remember. Also, this series of videos is purely for educational purposes. Do not attempt to use this for clinical or medical or professional use. This is for educational purposes. Unless professional use is that you're seeing this as my CV, then yes, please look, just see I'm a very serious psychologist. I am a very serious psychology student. Yes, so let us start here. This one now, the questions here, they are 10 questions and 1 case study, and this is a long form. The podcast will be in the description box. The episode may not be uploaded as I put the link in the description box, but that's a podcast I used to have. It's called Triangulated, the podcast where we talk about the shape of everything. You can go listen to my very, very old episodes that help in one way or another. Now, discuss the historical development of abnormal psychology. I do not think historical development will come for abnormal psychology. It will most likely come for psychological assessments and tests, but it's still good to know the stuff, Abnormal psychology is a scientific study of mental disorders, including their causes, symptoms, diagnosis, treatment, and prevention. Throughout history, explanations of mental illness have evolved from supernatural beliefs to modern scientific models. This evolution has greatly influenced current assessment and treatment practices. Supernatural model. In ancient societies, mental illness was attributed to evil spirits or demonic possession, witchcraft, divine punishment, curses. Treatment methods included exorcisms, rituals, prayer, trephination, which is drilling holes into the skull to release spirits. Although these approaches lacked scientific evidence, they reflected the cultural and religious beliefs of the time. And in class, we had an assignment, which I am actually going to read for you guys. The assignment was to go to a community and ask how do people define mental illnesses, what causes mental illness, what treatments are used or preferred. And I'm a Luo, and in my community there are things which I personally know sound like mental illness and treatments and all of that. And I still went ahead and asked, and I asked a respondent, and the respondent said, the Luo think mental illness is caused by jogi, meaning spirits of ancestors speaking through the person. There were specialists who dealt or treated quote and quote the illness. They had small gouts which was shaken severely. Like, think of the Nigerian movies where they're shaking gouts severally, and some of those gouts, Puga, spoke. Some were declared mad or bewitched, and sometimes an innocent person was accused of bewitching them. It was never viewed as an illness per se. And then there's this practice where child's blood is drawn and cutting of hand. I was like, what about the practice of cutting children's hair and drawing children's blood? I was told yes, they would take a razor sharp stone, incision on the forehead, tummy, nape, cheeks, rub some ash made of roots, leaves on it to wed spirits. Then I was like, is this something in particular clans? Or then I was told it's practiced in the wider Luo community right from Sudan, still practiced in remote areas. Autism, ADHD, etc. were considered jogi or bad spirits. So a child could have ADHD or autism and they'd be like, that child has bad spirits, jogi. And then I also asked, there's something called chira in the Luo community. Is it related to mental illness? And I was told yes. Chira, according to Luos, was a disease that made someone grow thin and thin unless a medicine man gave some medicine to see, meaning to cast out the spell, or because chira is consequences of abominations, e.g. incest, seeing your in-laws naked, having sex with a widow before she had been set free, chodokola. Yeah, chodokola. And then something else. You may think that these things are not practiced today. They are. I do know a Gen Z who has done this thing of where they raised a sharp stone incision on the forehead, tummy, nape, cheek. I know a Gen Z who's done that with a child, by the way. A Gen Z who's done that with a child. So These practices haven't gone. Some people still practice them. Let's go to the biological model. The Greek physician Hippocrates, 460 to 377 BC, rejected the supernatural explanations and proposed that mental disorders resulted from natural causes, particularly imbalances in the four bodily humors: blood, black bile, yellow bile, phlegm. Or is it phlegm? How was it said? Phlegm. His ideas laid the foundation for biological psychiatry. Modern biological perspectives focus on genetics, brain structure, neurotransmitters, hormones, and medical conditions. The psychological model in the late 19th and early 20th centuries marked the rise of psychological explanations. Actually, I think history will come, because in one of the past papers, there was a question about the theoretical explanation of mental disorders. You know, I'm doing this and then I'm remembering, wait, didn't I see this in the past paper? Then Sigmund Freud proposed that unconscious conflicts and childhood experiences contribute to mental disorders. Behaviorists such as Ivan Pavlov, John Watson, and B.F. Skinner argue that abnormal behavior is learned. I actually like B.F. Skinner's work. Cognitive theorists, including Aaron Beck and Albert Ellis, emphasize maladaptive thought patterns. These developments shifted treatment towards psychotherapy. Then we also have institutional care and moral treatment. During the Middle Ages, individuals with mental illness were often confined in asylums under poor conditions. Reformers such as Philippe Pinel and Dorothea Dix advocated humane treatment, leading to improvements in institutional care in the moral treatment movement. Community mental health movement. And I think this is when community psychology began and why it's an important unit to do. The 20th century saw the institutionalization and the development of community mental health services, emphasizing outpatient care, rehabilitation, family involvement, and social integration. The biopsychosocial model. This is something I've mentioned more than once. I've already done all the other videos. This is a video I'm redoing because my 26 plus minute video got corrupted. I was so mad. So the biopsychosocial model, today the biopsychosocial model is the dominant approach. It recognizes that mental disorders arise from interactions among biological factors, e.g. genetics, neurochemistry, psychological factors, e.g. cognition, personality, trauma, social factors, e.g. culture, relationships, socioeconomic conditions. The understanding of mental illness has evolved from supernatural beliefs to comprehensive scientific models. The modern biopsychosocial approach integrates biological, psychological, and social perspectives, providing a holistic framework for assessment, diagnosis, and treatment. And while I said in the beginning, maybe historical development of psychology, mental illness, and all that would not come in the exam. When I think about the question we were asked, in our cultural context, go and interview someone in your cultural context and ask them questions about mental illness. That is literally in the history of mental illness. Biopsychosocial model is here in the history of mental illness. And then there's something else, psychological model, because I saw that in a past paper, so it's probably gonna come. Critically evaluate the DSM-5 TR as a diagnostic manual. The DSM-5 TR, Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision. You know, you can be asked, define the DSM-5 TR, and then you fail to put and you write for instead of. Like in the first video, even though I corrected and brought on the screen, I had said Diagnostic Statistical Manual for Mental Disorders. The and was missing, the for replaced the of. It is Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision. TR means text revision. Published by the American Psychiatric Association, provides standardized criteria for diagnosing mental disorders. It is widely used in clinical practice, education, and research. The strength of DSM-5 TR is standardization, promotes consistent diagnosis across clinicians. What somebody in Congo is using to diagnose mental disorders and what somebody in South Korea is using to diagnose mental disorders are the same. Obviously, the cultural context is different, but the DSM-5 TR is standard across everywhere in the world. So in Congo, somebody won't diagnose schizophrenia one way, and then in South Korea, they diagnose it another way. They just create their own diagnosis criteria. Improved reliability. Clear criteria increase diagnostic agreement. Reliability of a tool is very, very important in psychology, so is validity. Treatment planning facilitates selection of appropriate interventions. Research provides a common language for scientific studies. Like when you get to the last video in this series, it's about vocabulary and abnormal psychology, and you'll come across terminology I felt like expounding on for my own memory as a practitioner and also for the exams. Provides a common language for scientific studies. Now that is in research. Communication enhances collaboration among healthcare professionals. A psychologist and a psychiatrist, if they don't understand the DSM-5 tier, it will be very, very difficult for them to collaborate. Those are similarities. And now when those are strengths, now when you look at the limitations, we have comorbidity. Comorbidity is the greatest limitation with the DSM-5 TR. Individuals often meet criteria for multiple disorders. Categorical approach. Mental disorders often exist on a continuum rather than in discrete categories. Cultural limitations. Some criteria may not adequately capture culturally specific expressions of distress. For instance, when I'm talking about mental health disorders in the cultural context, you'll find that some of those things, according to the culture, even if you immerse yourself in that culture, that, oh, this person doesn't have schizophrenia, this person doesn't have paranoid personality disorder, they are actually seen as a priestess. They are a seer over there. So medicalization. Normal emotional responses may sometimes be pathologized. Stigma. Diagnosis labels may contribute to discrimination and self-stigma. Somebody can be diagnosed with narcissistic personality disorder, but because of how things are going on the internet, this person is now going to feel stigmatized. Not every single person with narcissistic personality disorder is a horrible person. So many people with narcissistic personality disorder and even antisocial personality disorder are doing their very, very best to reintegrate with society and not harm others. It's not their fault that they have those personality disorders, but they're self-aware enough not to harm others. Some still harm others, but you need to know, many people with personality disorders are doing their very best not to harm others. They are doing their very best to understand why people live a certain way, how they live that way, and how they can join them in living that way. The critical evaluation of the DSM-5 is it should not be used mechanically. Clinicians must integrate clinical judgment, cultural context, functional impairment, comprehensive assessment. Although imperfect, the DSM-5 TR remains the most widely used diagnostic manual. When combined with clinical expertise and cultural competence, it provides an essential framework for diagnosis and treatment planning. Like, remember in the first video we talked about the difference between the DSM-5 TR and the ICD-11. Then explain the biological, psychological, and sociocultural models of abnormal behaviors, like the biopsychosocial model. Abnormal behavior is best understood through multiple theoretical perspectives. The biopsychosocial model integrates biological, psychological, and sociocultural explanations. The biological model attributes mental disorders to genetic factors, neurotransmitter imbalances, brain abnormalities, hormonal changes, medical illnesses. Treatment includes medication, electroconvulsive therapy, ECT, and other biological interventions. The psychological model, this perspective includes psychodynamic theory, unconscious conflicts and early experiences, behavioral theory, maladaptive behaviors are learned through conditioning, cognitive theory, distorted thoughts contribute to emotional distress, humanistic theory, psychological problems arise when personal growth is blocked. Treatment primarily involves psychotherapy. The sociocultural model. This model emphasizes poverty, trauma, family relationships, cultural beliefs, discrimination, social support. Interventions include family therapy, community programs, and addressing environmental stressors. Each model explains different aspects of mental illness. The biopsychosocial approach integrates these perspectives to provide comprehensive assessment and treatment. Discuss the assessment and diagnosis of schizophrenia. Schizophrenia is a severe mental disorder characterized by disturbances in thinking, perception, emotion, and behavior. Accurate assessment is essential for appropriate diagnosis and treatment. Assessment will need the clinical interview, mental status examination, medical and psychiatric history, psychological testing, physical examination, and laboratory investigations to exclude medical causes. Risk assessment, collateral information from family or caregivers. The DSM-5 TR diagnostic criteria for schizophrenia is that 2 or more of the following symptoms must be present for at least 1 month with at least one of the first 3. At least one of the first 3, of which we have delusions, hallucinations, disorganized speech. Those are the first 3. So at least one of the first 3. Grossly disorganized or catatonic behavior, negative symptoms. Signs of disturbance must persist for at least 6 months and cause significant impairment in functioning. That is usually in addition to signs of disturbance must persist for at least 6 months and cause significant impairment in functioning. Please keep in mind that I'm revising, so not everything is here. Differential diagnosis. bipolar disorder with psychotic features, major depressive disorder with psychotic features, schizoaffective disorder, substance-induced psychotic disorder, psychosis due to a medical condition. I will not expound on them here, but I have a video on differential diagnosis of schizophrenia in which we expound on the 5 that I have mentioned. Treatment of schizophrenia: antipsychotic medication, cognitive behavior therapy, CBT, family therapy, psychoeducation, social skills training, vocational rehabilitation. I personally find it very, very important that when somebody has schizophrenia, their family needs to be involved. There needs to be family therapy, and then there needs to be psychoeducation, even if there's nobody around you or who you know, or even in your family with schizophrenia. I feel like the general public needs to be psychoeducated on schizophrenia, because according to me, even in my undergraduate, I believe that anyone with schizophrenia is at a very high risk of their symptoms becoming severe when they face stigma, judgment, or they're treated badly by society because of having schizophrenia. You know, in my head, this is not schizophrenia related, but in my head, I'm thinking of Caster Semenya. Because growing up, I kept on hearing people say, are you Semenya? Ama wewe ni Semenya. Like in Swahili, ama wewe ni Semenya. Yule mtu ni Semenya. That person is Semenya. To mean like that person is like, you're a woman who looks like a man. They literally look at you and you look like a man. To me, Semenya looks like a woman, if you ask me. If you ask me. And then you're treated badly because of things that are beyond your control. For instance, if you're born intersex, it is not you who chose to be born intersex, and there's nothing wrong with you just because science long time ago never documented people who are intersex. Chances are they decided not to put intersex in science. Anyway, let's continue to what we are saying. A thorough assessment and multidisciplinary management improve prognosis and quality of life. Compare anxiety disorders and obsessive compulsive disorders. You will find this on Canva, by the way, the free templates I was talking about. Anxiety disorders: excessive fear or worry about situations or events. OCD, characterized by obsessions and compulsions. You'll come to learn later on, or I'll just remind you that there's a difference between obsessive compulsive disorder and obsessive compulsive personality disorder. And here we're looking at anxiety disorders versus obsessive compulsive disorder, OCD. Anxiety disorders include generalized anxiety disorder, GAD, panic disorder, phobias, and social anxiety disorder, while OCD, classified separately under obsessive compulsive and related disorders in the DSM-5 TR. Anxiety disorders: anxiety arises from perceived threats. OCD: anxiety arises from intrusive thoughts and is reduced through repetitive behaviors. Similarities: they cause significant distress and impairment, may involve avoidance behaviors, often treated with CBT and SSRIs. The defining feature of OCD is the presence of obsessions, compulsions, or both, whereas anxiety disorders do not necessarily involve compulsive rituals. These are the differences. Now we go to question 6, where we discuss depressive disorders and their treatment. Depressive disorders are mood disorders characterized by persistent sadness and loss of interest, leading to impairment in daily functioning. Types of depressive disorders are major depressive disorder, MDD, persistent depressive disorder, PDD, premenstrual dysphoric disorder, PDD. Yes, that thing you're calling PMDD is in the DSM-5 TR, by the way. You're not exaggerating anything. You're not all in your head. Don't let anyone gaslight you. You do need help. Substance or medication-induced depressive disorder. And I would say PMDD is situational and not on a continuum. But I think for PMDD, it overlaps because it's literally every period. So it overlaps between situational and continuum. We look at the meaning of situation and continuum in the last episode of Abnormal Psychology, Psychopathology, vocabulary. Symptoms in depressive disorders include persistent low mood, loss of interest, anhedonia, appetite and weight changes, sleep disturbances, fatigue, feelings of worthlessness, poor concentration, suicidal ideation. Treatment: cognitive behavior therapy, CBT, interpersonal therapy, IPT, antidepressants, e.g. SSRIs. And in the vocabulary section, we discuss what SSRIs are and what SSRIs is in full. Lifestyle interventions: exercise, sleep, hygiene, healthy diet, electroconvulsive therapy, ECT for severe or treatment-resistant depression, suicide risk assessment and safety planning. Treatment is most effective when it combines psychological, biological, and social intervention tailored to the individual's needs. Explain personality disorders using the DSM-5 TR. I have a video where we're explaining the clusters of the personality disorders according to the DSM-5 TR properly, and we have examples. This one we're just skimming through. Personality disorders are enduring patterns of inner experience and behavior that deviate markedly from cultural expectations, begin by early adulthood, and cause distress or impairment. The DSM-5 TR clusters of personality disorders are Cluster A, Cluster B, Cluster C. Cluster A and Cluster C have 3 personality disorders. Cluster B has 4 personality disorders. And Cluster A is odd stroke eccentric. This is paranoid, schizoid, and schizotypal personality disorder. Just add personality disorder to each. Paranoid personality disorder, schizoid personality disorder, schizotypal personality disorder. Cluster B, dramatic stroke emotional. We have antisocial personality disorder, borderline personality disorder, histrionic personality disorder, narcissistic personality disorder. Cluster C, we have anxious stroke fearful, avoidant personality disorder, dependent personality disorder, obsessive compulsive personality disorder. Remember earlier I said there's a difference between obsessive compulsive disorder and obsessive compulsive personality disorder. One is OCD, the other one is OCPD. One is a personality disorder, the other one is not a personality disorder at all. OCD is not a personality disorder. Treatment would be psychotherapy, e.g. dialectical behavior therapy for borderline personality disorder, CBT where appropriate. Medication for associated symptoms of co-occurring disorders, psychoeducation. Long-term psychotherapy is central to management with interventions tailored to the individual's need. Question 8. Discuss substance use disorders and intervention strategies. Substance use disorders involve problematic patterns of substance use that lead to significant impairment or distress. Risk factors are genetics, trauma, peer influence, mental illness, stress, poverty, easy access to substances. Did you know that if somebody in your lineage, could be your father, could be your grandmother, could be your mother, could be your great-grandmother, if there was a pattern of anxiety, even if you've been raised in the most healthy, in the safest environment, the fact that previous generations had anxiety means you are very likely going to be predisposed to anxiety. I saw people talking about it on TikTok, and I think they're referencing, what is this thing called? They're referencing a research paper. And it does make sense to me because Black people as a whole have certain behaviors that nobody has taught them, really. We've all been raised in different cultural contexts, different economic, different social contexts. But one thing that is common, if you feel like a house has paranormal activity, you are not exploring that. If you hear weird sounds in a building, in the forest, we are not exploring that. Then the whole thing also with water, and then the whole thing about doing all these very high adrenaline experiences. Yes, some people go do very high adrenaline experiences, but generally we do not do certain things. Some things we haven't been taught, but it's just in us, and we can tie that to slavery, by the way. We really can tie that to slavery. We can tie it to pre-slavery, pre-colonial parts of our communities. Yeah, they're just of each person's culture that have been ingrained in our DNA. And I think CRISPR also has something to do with that. I think we can CRISPR ourselves. Okay, I am deviating, but let's continue. DSM-5 TR features: impaired control over use, social impairment, risky use, tolerance, withdrawal. Intervention strategies are motivational interviewing, cognitive behavior therapy, group therapy, family therapy, detoxification where appropriate, medication-assisted treatment for certain substances, relapse prevention programs, community rehabilitation and support groups. Conclusion would be integrated treatment addressing biological, psychological, and social factors offers the best outcomes. Explain trauma-related disorders and therapeutic interventions. Trauma-related disorders develop after exposure to traumatic events such as violence, accidents, disasters, or abuse. Types of trauma-related disorders are acute stress disorder, post-traumatic stress disorder, PTSD, adjustment disorder, following significant disorders. I do not know why I have just thought of ASPD. I think it's Asperger's syndrome. I don't know. Is that a specific? I don't think it's a specific learning disorder. Specific learning disorders are dyscalculia, dyslexia, and there is a third one I quite can't remember. Asperger's syndrome may be a medical condition and not related to psychology. I don't know, it's coming to my mind. I'll go research. PTSD symptoms: intrusive memories and flashbacks, nightmares, avoidance of reminders, negative changes in mood and cognition, hyperarousal, e.g. hypervigilance, exaggerated startled response. Yeah, I couldn't help it. I went up and worked with Asperger's syndrome, and Asperger's syndrome was a former medical diagnosis on the autism spectrum characterized by social interaction difficulties and restricted interest, but without cognitive or early language delays. So yeah, I it would bother me. I just had to. And we already looked at, you know what, I'll restart from the PTSD symptoms, which are intrusive memories and flashbacks, nightmares, avoidance of reminders, negative changes in mood and cognition, hyperarousal. Therapeutic interventions would be trauma-focused CBT, eye movement desensitization and reprocessing, EMDR, exposure-based therapies, SSRIs were indicated, psychoeducation, family support, crisis intervention. Sorry if I'm repeating. Then we have early recognition and evidence, trauma-based focused therapies, improve recovery and reduce long-term impairment. I think we've reached that line, but I don't remember. Then we discuss the ethical issues in psychopathology. This is the 10th question. It's the last one, and after this we have a case study. Ethics are fundamental to the assessment, diagnosis, and treatment of individuals with mental disorders. Ethical practice protects client welfare and promotes professional integrity. Ethical issues include informed consent, confidentiality, and its legal limits. You really have to tell your clients about the limits of confidentiality. Accurate diagnosis and avoidance of overdiagnosis, professional competence, cultural sensitivity, respect for autonomy and dignity, beneficence and non-maleficence, managing stigma and discrimination, maintaining professional boundaries, appropriate documentation and record keeping. Ethical practice requires clinicians to balance client rights, professional responsibilities, and public safety while providing culturally responsive, evidence-based care. So, as a therapist, are you discriminating against people because they are of a different sexual orientation from you? Because of gender? Because of race? Because of religious, spiritual beliefs? You know, it's unethical. You cannot send someone away in the name of they are not heterosexual. There's no such thing as using the excuse of, but I'm not competent to work with people who are heterosexual. Chances are this person is not coming to you because of their same-sex relationships. That is really not going to be a competence issue, and it's really not an excuse. We all have to be competent. We really, really have to be competent, because if you're saying you cannot cancel somebody who is gay, lesbian, trans, or a member of the LGBTQ plus community, then how come you're able to cancel a man or a woman? How come? Anyway, let's move on to the case study. It's a very short case study. It doesn't have much meat on the bones. It's just one sentence, but here's the case. A 25-year-old university student reports hearing voices, believes neighbors are spying on him, has poor hygiene, and has withdrawn socially. What is the most likely diagnosis just from that sentence? Would you say it's paranoid personality disorder, or would you say it's schizophrenia? Just by looking at it, what would you say? Well, the most likely diagnosis is schizophrenia, as the presentation includes both positive symptoms, hallucinations and delusions, and negative symptoms, social withdrawal and poor self-care. Remember the first video we talked about positive symptoms and negative symptoms. Positive symptoms, what is being added, or negative symptoms, which behaviors have been reduced. The DSM-5 tier criteria to diagnose schizophrenia requires 2 or more of the following symptoms present for a significant portion of 1 month, with at least one being delusions, hallucinations, or disorganized speech. So now you're giving a reason for why you would say it's schizophrenia and not paranoid personality disorder. And this would be 1, delusions, belief that neighbors are spying. That is already there. Hallucinations, hearing voices, disorganized speech. And remember, including one of the top 3. And the top 3 was delusions, hallucinations, disorganized. It could be 1 or more. And this person has 2 of the top 3, which is delusions and hallucinations. We also have disorganized speech. We've not seen that in the case study. Grossly disorganized catatonic behavior. We haven't seen that in the case study. But negative symptoms, that is social withdrawal, poor hygiene, they do have them. Additionally, and I mentioned earlier something about additionally with 6 months, continuous signs of disturbance for at least 6 months, significant impairment in social, academic, or occupational functioning. Symptoms are not better explained by another mental disorder, substance use, or a medical condition. For instance, you feel like somebody has schizophrenia and they're also drinking or in drugs a lot. They go to rehab. After rehab, they no longer exhibit any of these symptoms mentioned above that are related to schizophrenia. It means that is now the differential diagnosis of schizophrenia, by the way, and you should go watch that video. This person's symptoms were as a result of substances or could even be health conditions. Possible alternative diagnosis includes schizoaffective disorder if psychotic symptoms occur alongside significant mood episodes, bipolar 1 disorder with psychotic features if psychosis occurs only during manic episodes, major depressive disorder with psychotic features if psychotic symptoms occur only during depressive episodes, substance/medication-induced psychotic disorder if symptoms are due to drugs or medications, psychotic disorder due to another medical condition, e.g. neurological disorders, endocrine disorders, or brain injury. And the treatment plan, which should be a comprehensive treatment plan, by the way, it should include biological interventions, psychological interventions, social interventions, and risk management. Biological intervention would be initiate antipsychotic medication, e.g. a second-generation antipsychotic, monitor medication adherence and side effects, assess and manage physical health. I repeat, this video is for educational purposes. I'm just revising. I'm not telling you to go and look at someone and be like, hey, you have schizophrenia. Yeah, I'm going to diagnose you. Yeah, I'm going to treat you. Do not. If you're not a licensed professional, if you're not even trained, properly trained, do not. Psychological interventions include psychoeducation for the client and family, cognitive behavior therapy for psychosis, CBTP, relapse prevention planning. Social interventions would be family therapy and caregiver support, social skills training, occupational or educational support, community mental health follow-up and case management. Risk management would be assessed for suicide, self-neglect, and risk to others. Consider hospitalization if there is severe impairment, inability to care for self, or significant safety concerns. And then prognosis is early diagnosis, adherence to treatment, strong family support, and ongoing rehabilitation are associated with better long-term outcomes. And that is the end of part 2 of revision for my abnormal psychology exam. That was responding to the long form questions and just one case study. In the past papers, we're going to have a number of case studies, and that's going to be in the podcast episode. I hope you enjoy this 7-part YouTube series. It's actually an 8-part series, but the 8th part is on my podcast because it's the past papers. Be sure to check my resources on Canva, the free templates I've made, so that you can also help yourself in revising. And always remember to use a DSM-5 TR and your clinical judgment. Somebody told me, their professor told them, use your clinical judgment a lot. The DSM-5 TR is very important. It's very good. You've already seen the benefits, the strength of the DSM-5 TR. But your clinical judgment is also very, very important, and you need to be culturally aware. So yeah, now it's time for me to go edit all these 6 videos.